Okay, IVUS and how it should influence your treatment plan below the knee. Obviously, this is something I'm very passionate about, and again, you're going to find that in my practice, many folks are like, well, does he really use IVUS this much? And then they get an opportunity to come and see the lab in both the OBL and the hospital, and they notice really quickly that this is really a part of our practice. Whenever we enter in blood vessels, we always use some sort of advanced imaging. It's one of the values, too, with using extravascular ultrasound, too, is that, again, you're adding some sort of adjunct to really understand what you're seeing. So next slide, please. I'll go ahead and try and fly through these. I only have 10 minutes. All right, so again, angiography gives you some luminal characteristics, but it just falls short when it comes to actually seeing the true vessel anatomy and what's happening on the inside. Angiography, it can make us feel good. We can make an angio look good, and you go back and look at it with advanced imaging, and you see that something is a little bit off. Next slide, please. So, here are the things you can see with IVUS. I won't belabor this. You've seen this. I think Eric showed some of these slides earlier. As far as vessel diameter and luminal diameter, your definitive treatment. So the plaque morphology, again, what are you going to see? What do you see when you're in there? For those of you that are using atherectomy devices and only have one single atherectomy device that you use, this is where I kind of challenge you. There are multiple different morphologies, and there are atherectomy devices that can tackle different disease morphology in a better fashion. And that's where the big challenge is. Take a look at the inside of that vessel and guide let the imaging guide what you end up doing for the patient. Next slide, please. Again, you can kind of see clearly, you get the acoustic shadowing from eccentric calcified plaque. Again, there's just so much more to the picture that you see whenever you're using advanced imaging. Next slide, please. And again, at the end of the day, what you choose to treat a lesion with, it should be based on what you see here. And you can see some of the pitfalls if you choose the wrong device to address this type of disease process. You can find yourself in a much longer, more dangerous situation. And that's less than ideal in any situation where you're dealing with complex lower extremity disease. Next slide. So some lesion characteristics that make us worried about restenosis, and this is even more apparent in the below the knee than I think in above the knee and in the iliac system. There's a lot of leeway in a vessel that is 6 millimeters in diameter, talking about the SFA, or the iliacs where you're dealing with 8 and 9 millimeters in diameter, or 7 and 9 millimeters in diameter. You leave in a 50% residual stenosis, that you can get by with that. Whereas in the tibial vessels, you've got a vessel that's 3 millimeters. Everybody's not blessed to have posterior tibial vessels that are 3.5 millimeters in diameter like Fadi. Ours tend to be a little bit smaller. And again, if you end up with a lesion that you haven't addressed, or you leave behind something that you don't think you have, then obviously that can be an issue. So with the lower extremity below the knee, this is even more important. Next slide. Here's a quick case. Go next slide, please. This ABI is showing toe pressures that are terrible. Here's our lesion. We've got a lesion in the popliteal. There's a question. Some people might treat that. Again, looking at this initially, it obviously does not look like it's hemodynamically significant, but we'll learn more in a little bit here. Here's the left, and then on the right, we've got our outflow, which isn't terrible, but there's certainly some work to do. Next slide. This is the lesion in question. Again, you probably wouldn't gather that you've got a 50% narrowing in the popliteal in the P2 segment based on arteriography. However, again, IVUS tells a whole different story. Next slide. So we just found the IVUS image down. I'm going to go ahead and skip this just for time's sake. Let's go on to the next image. You're going to have to take my word on what we see down the tibial space, and this really stood out to me. Next slide. I'm sorry. Go ahead and click, please. Keep going. We'll go to the third image, and we'll hold there. So in many of the cases that we do, and in your own practice, how many of you would, the posterior tibial is, it looks like it's a 3 millimeter vessel, so you could use a 3 millimeter balloon. Look at the different size discrepancies as you go along the various levels of the posterior tibial, and see how a more nuanced approach might change your management when it comes to these patients. These cases may get a little more expensive. You may have to use 2 or 3 different balloons if you're truly looking to address the disease process in a personalized fashion. Next slide. Next slide. And again, size matters. So here's the difference between the anterior tibial when you go from proximal to distal. So in these cases, I'll routinely use a 3 millimeter balloon and then use a 4 millimeter balloon. Yes, it costs an extra $100. However, if we're going to provide personalized care, this is, I think, in my opinion, is the way to do it. Next slide. So the whole point in all this, people think they can treat an entire vessel with one balloon. I don't think so. Some people use the same balloon for all 3 tibials. Come on, guys. That's a generalized approach. Patients deserve a more personalized approach. Some of you are probably shaking your head and saying, I can do better with arteriography versus IVUS and EVUS. You can't. I'm here to tell you, FIDE will tell you the same thing. You cannot do it. I don't care how much experience you have. There is a difference in what we see on arteriography versus what we see with advanced imaging. The next thing, clinical trials all show that we're leaving behind a 30% residual stenosis. I've been doing this for 10 years now, and I think I do a pretty good job. And many times I'm seeing 50, 60% residual stenosis and then putting in some extra work to get the better result. But again, I challenge you, if you think that you're leaving behind this, these great outcomes, go and take a look and see what you're actually leaving behind. It may surprise you. Next slide. We're going to skip through this. We've seen some of the evidence, and I showed this slide because there's when we talk about IVUS, a lot of folks say there's no evidence. There's nothing that really talks about IVUS. There are no randomized controlled trials, and that's fair. There haven't been these large, robust trials. However, we've seen time after time. You go and click slide. Go ahead and click through this and get each of those up if you can. All right, maybe. Okay, perfect. Okay, good. So you've got evidence and more evidence. And again, the momentum now, I think we hit an inflection point probably a couple years ago as far as intravascular ultrasound. This is going to be the future, okay? I really truly believe that, when it comes to interventions, we're going to be doing a lot more advanced imaging. And honestly, I don't care if you use extravascular ultrasound. I think it's equally advantageous. I think there are some advantages, but obviously that can be a little more labor intensive. But I encourage you to do something other than arteriography, even your multiple views. Guys, there are things, guys and gals, there are things that you're missing when it comes to these lesions. So we were able to get through with retrograde access. We interrogated with intravascular ultrasound. To save time, we like to do these interventions with retrograde, retrograde access, and we have our IVUS catheter, and we can work with that and do our imaging. We can slide up, do our, and interrogate an area, come back down, and do our treatment as needed. And again, it kind of saves some time as far as the treatment algorithm itself. So here's our pre and here's our final run. And you can see a nice difference. I did use an off-label coronary stent in the proximal AT. I use these liberally. It works the best of anything that we can do in the proximal tibial, and it doesn't burn any bridges when it comes to me doing a bypass later. And here is the final shot on the right. Again, just showing that wound blush. This is what every interventionalist wants to see in their life. When you got that wound blush, in all likelihood, you're going to get wound healing, which is obviously the ultimate goal. Here's our final IVUS run. We're going from the popliteal and going distally. I do things a little bit different with my IVUS interrogation. I typically would go anatomically. Actually, I tend to mix it up, but I'll go anatomically and go in the direction of flow. And so this is traveling down into the distal into the tibial vessel, and you can see that we've got some subintimal locations here, and then you've got some small dissections. I like to use chromaflow. It gives a kind of an adjunct as far as the actual flow that's at that level. It has not been validated, but again, with experience, you can tell different things. Here you can see pulsatility. This is in the distal portion of the AT. And so again, you know that you've achieved a good result. So I'm going to try and rifle through this second case. If I can, again, another example of use of IVUS and getting a great result. Classic patient, the access that we're getting here is in the very distal dorsalis pedis as it gets ready to take that dive down into the, deeper into the foot. Again, thank you, Fadi and Jihad for really helping to drive home this point. And again, one of the ways that I learned, again, these techniques. Here's our pre-procedure angio, okay. Go ahead and turn the volume down. I'm sorry, I may have forgot to take that out. Sorry about that. And here we go. Can we go back one slide, please? Sorry, I skipped over it. Okay, and then we'll go ahead and hit play here. We're real high tech in the OBL, so you have to excuse the squiggly lines. There's not much to see here other than a very diseased anterior tibial again. And here, after we've crossed the lesion, we have a retrograde access, wire flies right up, we get single wire control, and then we know that we can provide definitive therapy. So here's our next view of the anterior tibial, and again, you'll see that there's improved flow as we come down. There's emptying of the AT, and again, we've got our retrograde access. So on the left is kind of our final view and our final run getting down into the foot. And this is also, it's really a cool sight because what you're seeing is the competing flow between the anterior tibial and the posterior circulation as they get down to the foot. Again, I think this is really what you ideally want to see as far as flow and really know that you've achieved a good result. So thank you again for your time, and I hope you enjoyed the talk.